On behalf of the Department of Human Genetics and the Genetic Counseling Program, we're really excited to welcome all of you to the 15th Annual Diane Baker Alumni Lecture, and a special welcome to the 28 or so alumni that are joining us virtually through Zoom. Today, we'll be honoring Jennifer Fitzpatrick, a 1989 graduate of the University of Michigan Genetic Counseling Program. Before I have Beth come up to introduce Jennifer, I wanted to take a moment to first recognize Diane Baker, for whom this award is named. We're excited that Diane is here with us today to join in this special celebration for Jennifer. Diane's career at Michigan spanned over 25 years, and during this time, she founded the Genetic Counseling Program and served as our first director. In addition to her role as an educator, Diane provided genetic counseling in pediatric genetics, administered the state's newborn screening program, coordinated outreach clinics in northern Michigan, and provided local outreach to teachers and students. Diane's impact, of course, extended beyond just the University of Michigan and the state of Michigan, as she served in leadership positions in all of the National Genetic Society, including serving as president of NSGC and being a co-editor of the first textbook in genetic counseling. Diane is also a recipient of the Natalie Weisberger Paul Achievement Award from the NSGC. She was also involved in the 2008 passage of the Genetic Information Non-Discrimination Act, legislation that we all rely on in our everyday counseling as we try to reassure patients about their genetic information as they make testing decisions. Diane's impact in genetic counseling spans multiple generations. Like me, our awardee Jennifer Fitzpatrick was one of Diane's students. As you'll hear from Jennifer, she has served as director of the graduate program at McGill University for over 20 years, graduating over 100 genetic counselors. So Diane's pedigree is large, and her impact continues through her progeny. So thank you for joining us to Diane. And with no further ado, I think I'll have Beth come up now, our Associate Program Director, and she was also the chair of the selection committee, and she'll be introducing Jennifer.
All right, so thank you, Monica. I'm Beth, I'm the Associate Program Director. And before I introduce Jennifer, I do want to thank you. Thank the 2024 Diane Baker Alumni Award Selection Committee members that included Addie Beal, Fran Richardson, Agnieszka Lukashevitz.
Il faut juste que je finisse la transcription pour la France. Mais je vais voir si je trouve tous les documents, parce que s'il faut que j'écrive en France pour avoir une copie de son acte de naissance et tout ça, je laisse tomber. Attends, juste être sûr.
Can everybody mute who's joining us online? Thank you. And Rose Kemmerling, a current student. Thank you to the selection committee for reviewing our numerous applicants and helping select Jennifer Fitzpatrick as the 15th annual Diane Baker Alumni Awardee. So I'm very happy to welcome and introduce Jennifer today. As I was pulling up facts and little things to share about her today, I noted she is a 1989 graduate of the University of Michigan Genetic Counseling Program. Maybe I had football on the brain from Saturday, go blue, but I seem to recall something about 89 and a Rose Bowl, and I did a little digging, and sure enough, the 88 football team did become the Big Ten champions, went on to beat USC in the Rose Bowl in 1989. So I will now forever consider Jennifer a good luck charm for our Wolverines. But in addition to being a good luck charm, Jennifer has many, many contributions to the field of genetic counseling, just a few of which I'm going to share with you today by way of introduction. As Monica mentioned, Jennifer is director of the genetic counseling program at McGill University. She is an international leader and has had several service positions for the genetic counseling profession. At this time, she's assistant professor of human genetics at McGill, and she has been the program director there since 2005. Through her 30-year-plus career, she has had many noteworthy accomplishments in education and in service that I'm going to outline here for you now. In her clinical work, Jennifer has held positions in pediatrics at the Hospital for Sick Children in Toronto and at the University of Maryland Medical Center in Baltimore, prior to arriving at McGill in 1999. Once back in Montreal, Jennifer continued her clinical work in pediatric genetics at McGill, as well as in prenatal genetics at the Jewish General Hospital. Jennifer has contributed extensively to the profession of genetic counseling, holding several positions in professional organizations, including with the Accreditation Council for Genetic Counseling, the American Board of Genetic Counseling, the National Society of Genetic Counselors, and the Canadian Association of Genetic Counselors, where she served as president from 2003 to 2007. In her role as an educator, Jennifer has built the McGill program, teaching several courses, including genetic counseling principles, clinical genetics laboratory skills, introductory and advanced fieldwork rotations, and principles of medical genetics. She also has an impressive track record of funded research and publications. This has included the National Society of Genetic Counselors Special Project Fund that supported her work in the Duty to Recontact, a survey of attitudes of genetic service providers, as well as a funded project through the Canadian Osteogenesis Imperfecta Society, Osteogenesis Imperfecta, towards optimal maternal and fetal management. Her publications consider best practices in genetic counseling and genetic medicine, phenotype-genotype correlation, and work looking at the learning process and education in health sciences. A few recent publications include working on the establishment of core competencies for Canadian genetic counselors and looking at attitudes around clinical doctorates and other advanced education options for genetic counselors. In addition to all of this, Jennifer continues to advance her own education and research. She is currently pursuing a PhD in health sciences education. She holds a doctoral scholarship from the Social Sciences and Humanities Research Council of Canada and was awarded the Canadian Association of Genetic Counselors 2023 research grant for her study, Understanding Attrition from Genetic Counseling, the Role of Educational Programs. Alongside all of these accomplishments, as Monica alluded to, Jennifer has mentored and inspired numerous students who have gone on to be outstanding genetic counselors working in the field in diverse settings and roles. Thanks to her steady leadership, the McGill Genetic Counseling Program is recognized as one of the most competitive graduate programs in North America. So congratulations, Jennifer. It is an honor to present you with the 15th Annual Diane Baker Alumni Award.
So much for that wonderful introduction. It makes me sound really good. Can you all hear me all right? Yes? Okay, well, it is really a thrill to be here, to be back here. It's my first time back here in 35 years. So I took a little walk last evening and managed to find my old apartment. So that was a great start for this talk. I'm going to talk this morning about my path and share with you some of my memories from my extremely humble beginnings from my student days, and also share with you a bit about what I'm currently working on and engage you. Hopefully we'll have some time for conversation and feedback for any ideas that you might have. So I am Canadian. I was born in Montreal, Quebec, and I was able to speak French a little bit in early childhood, but then we moved to the Boston suburbs when I was 7, so I lost it all. I came back to Montreal for my undergrad and did a BSc in biology in 1988, and then came directly to the University of Michigan for the genetic counseling program. And back in those days, the program was only 18 months long, but you can see in both of my sort of class photos, I was always trying to get next to Diane. See? So I clearly felt the mentorship and the affinity. It started very early for me. So I would like to share just a couple of cases from when I was a first year genetic counseling student. So one of my very first participatory cases was a young man who was referred for preconception counseling for consanguinity. He was planning to marry his first cousin. And my supervisor at the time said, this is going to be a great case for you. It's a great place to start. Yeah, it absolutely will be. I'm so excited. This is going to go great. And what actually happened during the session was, so this is me. So you and your cousin, so we have 2 copies of every gene. And so you see, when you're related, so like there's a risk. It's not very high. And it went like this. And so after the session was over and the patient left, my supervisor said, well, I'm sure she used much nicer words, but what I heard was that was the worst counseling session for consanguinity I've ever heard. And so I burst into tears. This is what I heard, what I heard. Sure, she didn't say that, but I burst into tears and went, I know, it was terrible. So I learned a little lesson there, which was before one gives a new explanation of a genetic mechanism for increased risk, you have to work it out and you have to practice it. Good lesson to learn, especially early on. A second memory that I have from being a student was a referral of a young boy who was about 10 years old who was showing some features of Down syndrome, but his blood karyotype was normal. So we were, Les Biesecker, who was a fellow at the time, was going to do a skin biopsy to assess for mosaic Down syndrome. And so as we were walking down the hall, I followed Les and he turned around to me and said, oh, by the way, are you queasy? And I said, no. But what actually happened was the patient was lying on the table and the mother was at the patient's head, holding down his arms. And I was between the table and the wall, holding his legs with one arm and holding the sort of sterile test tube in which to put the sample with the other. And I was watching very intently, and you see the little punch biopsy, and Dr. Biesecker spinning it like this. And you see, sorry, this is feedback from my clothing. The little round ring of blood that just pops up, and I just kind of went over. And so I fainted, but not only did I faint like onto the ground, I fainted onto the patient, like onto this poor 10-year-old boy, and then I slid down the wall. And Les very kindly sent me a copy of the consultation report after, to the parent that said the results. And then P.S. the genetic counseling student who fainted on your son is doing fine. So I have this as a souvenir. So that's memory number 2. So the lesson there was try to figure out if you're at risk for fainting before you're in a situation like that. Memory number 3 was our first NSGC conference. It was so exciting for my classmates and me. This is a picture of me and one of my undergrad friends, Cheryl Citronbaum, and both of us got into genetic counseling programs at the same time. She went to the University of Minnesota. And so here's Cheryl and me, and I'm wearing a suit, literally a wool suit, because it was very important for us to look professional. But I don't know if you can see the wait staff in the photo next to it. You might notice something about my suit and then this suit. So at this conference, at this dinner, every time I stood up, someone would hold out their water glass for a refill. So that was a rather unfortunate wardrobe choice. So I guess, I'm not sure what I learned from that, just try to dress better, I guess. Anyway, for the students who are here, is there a common theme in these 3 cases, or is there a common thread that you can identify? Go ahead. Right, exactly. Yes, thank you, Madeline. It's not going to be perfect. Stuff's going to go wrong. Stuff's going to go wrong. And we can't focus on the things that go wrong. We tend to, but if you can, as students, try to hold on to the things you're doing well also, and try to make memories of those and think of those moments often, so you can lay down some good tracks to carry you through the times when things don't go so well. So from very humble beginnings, the next 35 years were definitely better than that. So I started my career at the Hospital for Sick Kids in Toronto, where I did pediatrics, and I have very fond memories of Diane passing through and visiting me there. So in Toronto, I met my current partner, my husband, who was doing a residency in medical genetics. And he then had to do 2 postdocs. And so I followed him. And so we went to Paris, which was not tough. But I did have to learn French, or I should say relearn French. So I spent 6 months at l'Alliance Française, taking full-time French classes from 9 to noon. And then when I got to a certain level of conversational proficiency, then I volunteered with Ségolène Aimé, who had a research program. So that allowed me to become involved with the local genetics research community. And so at the time, it felt like I was taking a big risk. I sold all my furniture, sold my car, gave up my apartment and all my friends, and quit my job. I didn't speak French, I didn't have a job, and I didn't even have a work permit. So it was kind of a risk. But what this episode taught me is that sometimes you have to take risks if you want to do something new and exciting. So detour number 2 took me to Baltimore, where I worked at University of Maryland Medical Center. And that was a quick 2 years. And then my husband and I ended up back in Montreal. And by 1999, had 3 little ones who kept us very busy. So Alex was born in 1997, and the twins were born in 1999. But so at that time, I started working back in clinical jobs, but very quickly there became an opening and a need for a genetic counseling assistant program director. And so that all of the bits and pieces of my past prior to that time all started to fit together and make sense. So I had been exposed to 3 different GC programs. I had been here, trained here at Michigan. Then I was in Toronto, where there was a program in development, and in Maryland there was a GC program, and I supervised students and taught some classes there. And so McGill, once I arrived there, they wanted people who had been elsewhere, and they wanted somebody who had some fresh ideas for their program to turn it around and help it achieve accreditation. So everything really was for the best. Some of you probably know Janice Edwards, who has recently retired as the program director at University of South Carolina. In 2006, in 2006, Janice was awarded the Jane Engelberg Memorial Fellowship. And this was to bring together an international group of genetic counseling program directors and heads of professional societies. And so I was fortunate enough to attend this meeting, which really opened my world. Participating in this first international meeting showed me what a good idea can do. There were almost 100 people from all across the globe, and we were all meeting each other for the first time. It also taught me that if we want to make a change or expand our horizons, it's really up to us. Come up with a good idea, apply for funding, and see what happens. At this meeting, I was put at a dinner table sitting next to Dr. Moeen Al-Sayed, who is who was a medical geneticist from King Faisal Hospital in Riyadh, Saudi Arabia. And I thought nothing of the long conversation we had. I thought, oh, I learned a lot. He sent me a little book afterwards. But then a couple of years after that, he invited me to come to Riyadh and give 2 lectures for a conference and speak about genetic counseling and GC education. And I was hesitant to go because my kids were really little. It was really far. I was going to be exhausted, but I decided that it would be good for me to go, and I'm so glad I did. I learned so much. This is not Dr. El Sayed here. This is my local genetic counselor host. This is her father. She invited me back to her family home, and she would not be photographed without her headscarf. And so, but she said, I'll take a picture of you with my dad. So the lesson here that Wendy once had me do a video for the GC students here a long time ago, the lesson here was just say yes, because you don't know where the opportunities will come. And I'll also just share with you that just this week I was asked to be the external reviewer of the GC program in development in Doha, Qatar. So I'm going to go in April. And that's Dr. Al Sayed. Okay, so what's next? So there was this kind of 20-year period of doing a bit of clinical work and then running the GC program. Like many of us did during the pandemic, I started to reevaluate how do I want to spend the rest of my career before retirement? I've got maybe 10 years, 10 good years, maybe, and then some. I felt that the profession doesn't, we still have a ways to go. Certainly in Canada, we're not quite as far ahead as you are here in the US. We need a research track. We should have a school of genetic counseling at McGill. It doesn't make sense for a clinical education program to be within a basic science department. I want us at McGill to be with the School of Nursing, the School of Medicine, School of Physical and Occupational Therapy. That is where our natural home should be. But to make this happen, I felt that I needed to upskill. And so I decided to apply for a PhD program in health sciences education. This is where my current PhD program is located. It's in a beautiful old house. It's called Lady Meredith House. You can't see how much it's crumbling down, but it is lovely from the street. But so my question in making this shift and in making room for further studies is, what do I want to study? So if you want to do an advanced degree, you have to have a pretty good idea of what could make a decent research project. And I thought of the thing that is the most vexing and the most difficult and challenging for people who are running clinical education programs. And that is when students, for whatever reason, just can't do it. They're unable to achieve clinical competency. So when I talk about attrition, so attrition refers to leaving or quitting or dropping out. But in genetic counseling, we're mostly referring to that happening because the student is unable to master the clinical competencies. By the time GC students get to a GC program, they know exactly what they're getting into. It is their dream. It almost never happens that a GC student says, "Ooh, this isn't what I thought it would be." They're not leaving because of that. They're leaving because for whatever reason they can't complete. So this is a very, very difficult and sensitive topic. But that's kind of what I was seeking in graduate studies. I wanted to take a problem that is challenging. So genetic counseling education in Canada is tiny. We only have 5 programs, and the number of students is in parenthesis next to each. Total graduates per year across the country is only 27. So if we lose anybody, we don't want to lose a single student because we have so few. The applicant pool is strong, as it is here, and most students, of course, do very well, and they achieve competency. But I did an informal poll of my counterparts across the country, program directors, and asked, over the last 20 years, how many students have had a really difficult time, maybe had to do an extra year or failed to finish the program? And I got a certain number, and it turned out to be about 1 in 20. But what's really problematic is that over 50% of these students were from underrepresented backgrounds. And that means in genetic counseling, it means non-white and non-female. So compared to a figure in the genetic counseling world of maybe 11% that's in this demographic, over 50%, there's a problem somewhere. And so this was further rationale, even though it's unofficial data and the numbers are small. This is a little bit of a red flag that I felt really should be looked at. So making some observations, thinking about what is the history of our profession. We're still emerging, we're still fighting for legitimacy. I remember being very, very proud of the fact that GCs wrote the same certification exam, the same general exam, as did our doctoral colleagues. And this was an important part of our identity, which we had to let go of at a certain point. But I wonder, how much that fight for legitimacy still colors our expectations of students and the way we practice and the standards to which we hold ourselves. Like, it's not good enough just to be good. We have to be awesome. We have to be stellar. And then genetic counselors are still overwhelmingly within a very restricted demographic. And that, we know we need to change that. So thinking about all of these different elements of our profession, could these all be related somehow? Is there some relationship between what our expectations are and what we want for our students? And could there be maybe an intolerance for difference somewhere? So these are all very subjective, but it's what I chose to study. So this is the title of my current proposal. I'm very early in the process. I haven't defended the proposal yet or passed my comps, my oral comprehensive exam, but that should be in the winter, hopefully. My supervisor is Aliki Thomas, who's an occupational therapist researcher, as is a member of my committee, Ann Kinsella. Salim Razak is a pediatric intensivist at University of British Columbia with a professional focus, a research focus on equity, diversity, inclusion issues. And then Claire Davis is a genetic counselor at Sarah Lawrence College, and she's the GC, the American GC member of my committee. Attrition is not unique to genetic counseling programs, of course. Attrition happens across health profession education programs. It varies, it goes up and down over time, but it's consistently there. It's never zero. There's a lot of research on student-related factors, such as being demographic characteristics, being the first in the family to go to university, being Indigenous, Black, Mexican American. And then there are a lot of papers dealing with the personal behaviors and characteristics, things that go with failing to complete the program. And these are observable behaviors such as unsafe or unethical behavior, maybe like plagiarizing patient letters, or just things that students may do out of desperation if they don't know how to do it themselves. Learning disabilities that are undiagnosed, mental illness that's not appropriately treated, personality disorders. All of these can influence whether a student is able to be successful. And I would say it seems that most of the research is looking at students and what is happening with students. However, it behooves us also to look at institutional factors, program factors, things that are happening on our end of things as educators. So we know there are a lot of factors here as well. So large class sizes, student placement policies, not enough time with your supervisor, not enough academic supports, systemic barriers. All of these are important too. And I thought that it really, we need to maybe pay a little bit more attention to these factors when we notice that there's an overrepresentation of underrepresented students who fail. Consequences of dropout, you know what they are. They're terrible. It's very detrimental to the morale of programs, university finances. In a society that, like in Canada, where we have public health care and higher education are taxpayer funded, it's a waste of taxpayer dollars when students don't complete, as well as it contributes to a paucity of practitioners. For students, though, it's the worst outcome. They have an altered sense of self. It's very demoralizing, and there's really very few, if any, off ramps from clinical programs to other types of degrees. There's really nowhere else for a student to go. They just end up having to leave. So some researchers have called this a wicked problem because it's so complex and so hard to prevent or fix. So my future focus is going to be, is the genetic counseling education system contributing to this phenomenon? These are my research questions. I'll just give you a second to look them over while I have some water. To address the first question, this is going to comprise my a narrative literature review, looking at the history of genetic counseling education. Who decided on the curriculum? Why did they create it that way? Why did they think studying X, Y, or Z was important? How did we decide to have in-room direct supervision compared to other models of clinical supervision? And then questions 2, 3, and 4 are going to be part of the empirical study. And I'm using a qualitative approach called collective case study. So here, we are not talking about like a case report, like as you see in biomedical sciences or in medicine. A case study is a qualitative approach where you get a really deep and thick and rich understanding of a phenomenon in its natural context. A collective case study is a variation of this where you collect a bunch of cases and put them all together. And because I'm studying something that's so sensitive and programs are small and individuals may be identifiable, I'm collecting data for all of them bounded together. So collecting data across programs, and the data will be pooled in the analysis so that no program or former student would be identifiable. So again, going to take a 20-year period that will not involve any current students and collect data by mostly interviews. Speaking with GC program directors and supervisors, asking them to reflect on the students who they worked with who didn't do well. What do they remember about these students? What do they remember about the issues? Talk to me about what you think was going on for this particular student. And then the interviews will be recorded and transcribed and subjected to some thematic analysis. This piece is the most important, I believe, and this is the individual interviews with former students, whoever I can get among this group who will talk to us. I won't be interviewing my former students. We'll have another member of my supervisor's research team doing those interviews. But this is a very underexplored group of research participants, and I think that their voices need to really be heard, and they will have the most value for us. And then a final review will be documents like admissions policies and graduation policies and remediation policies, and just see whether there's anything to learn from those. Hopefully, my findings will tell us something about any program-related influences in student attrition, give us some ideas of things we can work on, maybe enhance retention rates, and be relevant to other health professions programs. So I just want to take a pause and ask, is it 60 minutes already, or how much time? Oh, great. Okay. All right. So what I have learned is that when we are doing qualitative research, we need to engage with theory, because the theory is what connects you to other researchers who are working on the same issue. Qualitative research often involves very small groups of participants, which is obviously not generalizable the way we think about it in biomedical sciences, but it can be transferable to other groups and other settings and other programs if we connect it with a specific theory. And so two theories that I'm playing with and interrogating right now is the idea of the hidden curriculum and the theory of belongingness. Who's heard of the hidden curriculum? Yes? Would any of you like to share what your understanding of it is? Stuff that you expect of students that perfectly said. Right, the stuff that we expect from students that isn't written down formally on paper anywhere. So when we say this, what we mean is this. So some examples of the hidden curriculum could be we expect students to show up on time. We expect them to ask questions. We expect them to be self-directed. These are things that may or may not be written down, but that students get the message. The hidden curriculum was introduced by a primary school educator, Philip Jackson. And the definition is, as Monica just said, it's was taken up a little bit more recently by Hunter and Cook. And newer researchers highlight the fact that the hidden curriculum also serves not just to get students to behave in a certain way, but it serves to preserve the existing hierarchy and the existing power structures. And so if we teach little kids in primary school, for example, that they have to be quiet in class, they have to be respectful, they have to show deference to their teachers, this also preserves the teachers as being the ones in power and in control. So this is the idea for the hidden curriculum. Frederick Hefferty brought the hidden curriculum to medical education. And a lot of researchers have gone on to describe explicitly the benefits and the limitations of this expectation of learners. For students, the hidden curriculum is a really strong socializing force. Those who succeed have picked it up and have sort of gotten a lesson. Like if I'm in a clinic meeting and the geneticist says, oh, we need to find an answer to this question, I should volunteer because I'm a student. And this is the unwritten expectation. And if a student is asked to do something, they will say, yes, how soon do you need it? That's our expectation. So thinking about what are our unstated expectations of the learners with whom we interact, residents, fellows, GC students, each other, Are there any other expectations that we hold or that you've sensed as students that haven't been written down anywhere? Anybody think of anything? I've got one from when I was working at Sick Kids. My husband at the time was a resident, and we would, in order to see him, I used to have to work late because he was there late. And so at one point we were there, it was about 11 o'clock at night, and he faxed something to a colleague back in Montreal. And he said, well, the rule is that we can't leave before they do. And so I know that Dr. Mitchell works until late at night, so I'm going to send this at 11 so he knows I'm still working. Unfortunately, Dr. Mitchell faxed right back. And so, but I was shocked by this. But so that's an example of the hidden curriculum for residents. You have to work harder than your staff. Anyway, so the hidden curriculum may be exerting its force subtly and may be helpful as a working theory. Students who don't get or are unable to pick up the hidden curriculum may not do as well. And the second theory that I'm thinking about is that of belongingness. And here is a theory which is so obvious that it's surprising to me that we don't talk about it or haven't been talking about it explicitly. But so this is going back to Abraham Maslow, who was an American psychologist. And you probably know his work from the hierarchy of needs theory. And this is where you have the physiological needs for food, water, and rest, and then safety and security as being, you know, the primary needs that must be met. But then right above those, you have belongingness and love needs. So this is really considered to be a primary psychological need. The idea is that our ancestors living in social groups were more likely to survive and pass on their genes if they belonged to the group and if they shared resources and if they took care of each other's offspring. And so that the need to belong has been selected for in evolution. And certainly in genetics, this is intuitively, it resonates. It's like, yeah, obviously. So here's kind of a current definition as we see it in health professions education. And you can see how a sense of belonging would be really helpful to foster student performance and motivation, resilience, protection from burnout, and how if belongingness is impaired, this can really prevent you from doing all those things. More recent researchers have started to tease out different domains of belongingness. There's the social belongingness, academic, professional. We may feel belonging in our social world, but not belonging in our academic world, et cetera. And then McKenna et al. Discusses how achieving and being self-actualizing, becoming the professional you want to be, a physician, a genetic counselor, a researcher, really requires work at this level first. You can't have your self-actualization unless you feel a sense of belonging. And most recently, Catherine Allen and her group in Australia have really taken up the theory and really started to interrogate it formally. So I think we're going to see more papers coming out using this theory to talk about so many of the challenges that we have in health professions education. And certainly it would have a huge role to play in whether or not we are truly welcoming as genetic counseling and other health professions programs. So I will end here and thank you. And I'm thanking my funders for my future work, and I'll take questions.